Un, deux, trois, test micro. 1, 2, 3, test micro. Un, deux, est-ce que vous me recevez? Un, deux, test micro, 1, 2, 3.
Ok, si vous voulez, je mets un petit peu plus fort. Non, parce que les gens vont faire. Et ceux-là, je les ai réglés de façon plus. Par contre, n'oubliez pas que là, par exemple, je m'accorde un petit peu en dessous. Si on va pas, ils vont. Non, on ne va pas les entendre sur ce bas. Les coups sur la table. Oui. I think we'll do the mics automatically activated. This one will be meeting I'm here already, but across the table. Interesting ones. Yeah, you don't also don't know where the landmines are, but you don't bring fun back. Trying to embrace the good idea.
Oh, so she
Was it Mark?
that's probably why.
Yeah. I think this is fine. Stuffing a lot into it now.
Unfortunately, we have not
Yeah. I worked at things there. Moderators.
your acknowledgement. More than enough. Let me know.
Okay. Give each other marks.
There's all these people.
I'll punch it around. I don't need to be up here.
Hello. Hi, good afternoon. We'll get started now. Thank you for joining us today on the topic of mental health and human rights towards community-based mental health care. This event is organized at the margins of the 78th World Health Assembly by United for Global Mental Health and the Office of the United Nations High Commissioner for Human Rights, and co-sponsored by the governments of Brazil, Mexico, and Portugal. We're so excited to have you here. My name is Veronica Cho with the Global Mental Health Action Network, and it's my privilege to be moderating this event. As a global mental health researcher with my own lived experiences with mental illness and involuntary institutionalization under the psychiatric system, this work is deeply personal to me. The opportunity to have this discussion on deinstitutionalization, community-based approaches to mental health care, and policy reform grounded in human rights and dignity is not lost on me. These issues are complex and multifaceted, especially across different jurisdictional and sociocultural contexts, where institutionalization intersects with systemic challenges and often exacerbates health and social disparities, especially among marginalized and racialized communities. People with lived experience have long been at the forefront of advocating for change, calling for rights-based approaches and meaningful involvement in decisions about their own care. And yet, despite growing international discourse on deinstitutionalization, many people with mental illness are still detained for extended periods of time, still subject to restraints, or forcibly medicated. I would know. I've been there. This event will provide an opportunity to share good practices and lessons learned on transitioning to community-based mental health care and supporting deinstitutionalization at the national and international level. It will also showcase the importance of applying a human rights perspective to mental health and gather support to make the issue a global priority at this week's World Health Assembly and beyond. It has never been more urgent to prioritize mental health on the global health agenda and to make our calls to action impossible to ignore. So, before we begin, I would like to remind all participants that the United Nations has a zero tolerance for any form of harassment, including sexual harassment. The UNOG Director General has pledged to implement the Code of Conduct to prevent harassment, including sexual harassment at UN system events. I would also like to mention, as you can see, that this event is being live streamed virtually. And so hello to everyone from all over the world, whether it's morning, afternoon, or late in the night. Online participants are encouraged to engage and ask questions to the panelists. So without further ado, I would love to introduce our two opening speakers, Michael Camilleri and Sarah Klein. And I'm going to introduce Michael to speak first and then Sarah afterwards. So it's my great pleasure to introduce Michael Camilleri, Chief of Branch of the United Nations Office of the High Commissioner for Human Rights. He has engaged on human rights in countries across the globe with a particular focus on the Americas and has undertaken work on a wide range of issues. And I was blown away reading your bio, Michael, including on human rights defenders, enforced disappearances, gender discrimination, gender-based violence, freedom of expression, anti-corruption, labor rights, sustainable development, and digital democracy. And that is just scratching the surface. I welcome Michael Camilleri to please provide his opening remarks.
Thank you, Veronica, for the very warm introduction. Thank you for your leadership and courage as well. Excellencies, colleagues, friends, it is a great pleasure to welcome you to this event as we mark the opening of the 78th World Health Assembly. Let me start by extending my gratitude to United for Global Mental Health, our partner in organizing this conversation on mental health and human rights. Thank you, Sarah. Allow me to share some very brief reflections on the genesis of the right to health by taking us back to the 1950s. The then UN Human Rights Commission and the Third Committee of the General Assembly were in the midst of discussions on the provisions of both human rights covenants. During deliberations on the draft article on the right to health, delegations decided in the end not to embark on defining what health was. However, they were heavily inspired by the definition which had been included in the then recent constitution of the World Health Organization, and in particular, the explicit acknowledgement that mental health was and is an intrinsic part of health. And as a result, Article 12 of the International Covenant on Economic, Social, and Cultural Rights refers to the right to the highest attainable standard of physical and mental health. Distinctions between physical health and mental health have always been artificial, as we all recognize there can be no health without mental health. However, public policy has been slow to catch up to this reality. While the WHO estimates that 1 in every 8 people live with a mental health condition, mental health remains far from enjoying parity with physical health in policies, budget allocation, or treatment coverage. For example, more than 75% of persons with mental, neurological, and substance abuse disorders in low and middle income countries receive no treatment at all. In many countries, only 2% of government health expenditure is dedicated to mental health. Let's be frank, despite some progress, mental health remains a taboo in many societies. Stigmatization and discrimination of persons with psychosocial disabilities and users of mental health services continue to be pervasive globally. Equally concerning, laws and health practices related to mental health in all regions continue to include coercive and institutionalized approaches. Our key message today is the following. Human rights provide us with the transformative framework to address these issues and to require holistic mental health systems that are people-centered and prioritize inclusion and equality. The UN Human Rights Council has recognized the centrality of human rights for the advancement of the right to health, including mental health. And in March of this year, the High Commissioner for Human Rights presented to the Council a new report on mental health and human rights. The report underscores the urgent need to adopt a human rights-based approach to mental health as a fundamental element of the right to the highest attainable standard of health under international human rights law. It also contains a set of actionable recommendations to states and stakeholders, such as the shift towards community-based, rights-centered mental health care and ensuring free and informed consent while eliminating coercive practices such as involuntary commitment and forced treatment. Concluding, let me refer you to the mental health, human rights, and legislation guidance produced jointly with WHO, which specifically seeks to support countries and other stakeholders towards embarking on the legislative reforms related to mental health that are required by the human rights framework. Our office stands ready to provide technical assistance in such endeavors. I wish you fruitful exchanges today and look forward to both an enriching conversation this afternoon and many future collaborations. Thank you very much.
Thank you very much, Michael. I'd like to now introduce Sarah Klein to provide her opening remarks. Sarah is the fearless leader, the CEO and co-founder of United for Global Mental Health, and an internationally recognized expert in mental health advocacy, previously at the WHO, World Bank, the UK government, and Oxfam. Please give a warm welcome to Sarah.
Thank you very much. I'm glad I've worn my sneakers because I've already ran down the hill once, and I'm sure we'll be running up and down the hills over the coming days. But I think that's a fit way of thinking about mental health. We've been running and running and running for so long to be heard, and I really appreciate this event today with our partners. This is the first World Health Assembly that I think I've ever been to where mental health is on the agenda in so many places, and not just us running and running and running to make you all hear what we want to say, but all of us working together. And I'm particularly appreciative of the different governments who are here today to speak about their work and what they're doing. It's a big moment for all of us. So thank you again to OHCHR, to Michael, to David, to Khalid, to Jera, to everyone who's helped make this event happen. And of course to my team, particularly to Ali, who's done an awful lot to help you be all here. There is nothing more important than a human rights-based approach to mental health. And it's important, as I've said, that we all work together on this. At the moment, the world holds more people in mental health institutions than in prisons. Conditions can be terrible, and you will hear from various people about the conditions in which they have experienced their mental health in institutions, and I have witnessed it for myself. We need to end institutionalization in favor of human rights-based care, and particularly a focus on the recovery rather than the retention. And I think that's a huge change. At the moment, it's about locking people up rather than freeing them from their mental health conditions and helping them live within society and fully exercise their rights as a citizen. Change is possible. There are lots of examples, and we know that change can happen. We have a new report coming out later this month or next month, setting out more details. But again, you will hear lots of positive stories today. Change is possible, and it's so important. We know that at the moment, a very small proportion of health budgets are spent on mental health, but most of that budget is spent on institutions. It's spent on locking people up. This is not acceptable. It's not really what mental health professionals want either, and it certainly isn't what families and communities want. They want their loved ones back with them, their fathers, their mothers, their children, their aunts, their uncles, their teachers, their doctors. They want them back in their communities, and together we need to make that happen. There is WHO guidance also coming up on deinstitutionalization, and we've already heard about the great work WHO has been doing on upholding human rights and talking about things such as quality rights, which has been a way in which to educate people about rights and rights-based care. Going forward, we need to build awareness and demand for this approach. As I said, we need to work with people with lived experience themselves, but also with families, with health professionals, with governments, with all of you. The UN high-level meeting later this year on NCDs and mental health will be critically important. This is the moment at which the international community can come together and can say that they are fully committed to deinstitutionalization and to a recovery-based approach to mental health care. This is what we're asking for, and we're asking all of you to join with us. Thank you.
Thank you, Sarah, so very much. I would like to move to the first of two panels we'll be having this afternoon. This panel will be providing varied perspectives on rights-based mental health governance. I will take the pleasure of introducing the panelists one by one and provide each of them an opportunity to speak directly on their expertise and experience on this topic. So it is my honor to introduce His Excellency, Honorable Minister Dr. David Krishanovic Stalnikowicz. He is the Minister of Health of Mexico and has served as president of several professional organizations, while his contributions to medicine have earned him numerous prestigious awards. He received the Medalla Emerito in Ciencias from the Legislative Assembly of the Federal District in recognition of his contributions to science. So I would love for Honorable Minister to provide your remarks. Thank you.
Well, first of all, I would like to thank the opportunity of being here and discuss the issue of mental health. Before I say some words, let me tell you that the issue of mental health before COVID was something completely different than what happens after COVID. After COVID, we had problems related to isolation, which was for young people, isolation for adolescents, and isolation for older population. And all this brought the issue of mental health in different ways. We have the problem of mental health by itself, and we also had the problem of addiction in the population. So I think that was an important turning point on mental health. And for this reason, I think we are brought here for something which is an urgent case, at least in our country, and I think from when I listened now, it's an issue which is very important in other countries. And that is the transformation of the mental health care system, because we need a different approach to mental health. And this must begin with a new and better understanding of what mental health means as a human right, anchored with the dignity of every person who suffers from mental health. For decades, as you mentioned a few moments ago, the prevailing model has been centered on medicating and isolating persons rather than integrate people who struggle with issues of mental health. Today, we are called to move beyond that model and to build mental health governance grounded in human rights. For the government in Mexico, mental health is now a priority. We have reformed our legal framework to put mental health and addiction prevention as one of the leading issues in our health policy agenda. Through the creation of a National Commission on Mental Health and Addiction, which we called CONASAMA, which has to do with the name that it has in Spanish. In 2023, the Minister of Health has now become the leading authority responsible for mental health policies, providing specialized services and primary care. And I want to mention primary care as an important issue in the aspect of developing a policy for mental health. And the CONASAMA is now responsible for the creation of community-based strategies with a primary care health approach. This framework allows for greater cooperation across sectors and institutions and more streamlined decision-making across the country. In October of last year, our President, Dr. Claudia Sheinbaum, took office as the constitutional president of Mexico, launching a national preventing and ongoing campaign aimed at preventing substance abuse with a strong focus on young people. The message is clear: stay away from drugs, fentanyl kills, choose happiness. The campaign focuses on increasing the dissemination of information, strengthening education, and promoting actions for self-care and well-being. But that is only for one aspect of mental health, and it has two pillars. One which has to do with the Ministry of Public Education and the Ministry of Culture, focusing on prevention to training, weekly pedagogical interventions, and facilitating access to current evidence-based information, and it's aimed to teachers, tutors, parents, family support, networks, and young people with clear messages and practical tools. The second pillar, coordinated by the Ministry of Health, focuses on care. It involves interventions across the health sector that are implemented by all health services institutions through the country, not only to those specialized in mental health, but in all the different kinds of institutions. These actions have the aim to reduce the treatment gap in mental health in general. The campaign's main objective is to inform adolescents and young people about serious risks of substance abuse and to promote well-being. One of the most far-reaching interventions has been the setup of something that we called in Spanish La Línea de la Vida, which in English means the lifeline, which is a national 24 hours, 7 days a week telephone counseling that offers guidance, emotional support through psychological first aid and brief counseling, strengthening the integrated health service networks, and establishing intersectoral partnership with emergency services nationwide. Why do we need this call? Because what we've seen after COVID is an increase in suicides in the country. And the population which is at more risk is young people between 9 and 15 years. And that is a parameter and a very good indicator of what mental health means, and something we can build up in trying to prevent and see the effectiveness of any kind of measures that we have. So this lifeline functioning 24 hours, 7 days a week has proven to be very significant in the numbers of people accessing to it, and we'll have to wait to see the results. Another very important issue we're working in the mental health is the mobile population, because they are one of the most vulnerable groups. Population that goes from one state to other state, and there is the migration of workers, etc. And this kind of population has different accesses to services. And we've had now a component of repatriation strategy called Mexico OHCHR that has provided support for the migrating population, moving from one country to another country or from one state to another states. Mexico's legal framework today prioritizes individual autonomy and the right to freely decide on therapeutic procedures. The involvement of family members or legal representative is allowed in cases of emergencies on disability only, and for the rest, no such figures are available, and all actions need to be documented in the clinical record. The transition toward a primarily preventive and community-based model is accompanied by measures to dismantle the asylum-based model. The General Health Law now mandates that institutionalization must be a therapeutic last resort option, and that all procedures must adhere to ethical and social principles with full respect for human rights and personal dignity. We want mental health to be part of daily life, not something addressed only in moments of crisis, hidden away due to stigma. It is time to recognize that mental health is not built solely in clinics. It is shaped by public policy decisions, by economic security, and by community engagement. It's not only the responsibility of the health sector, but it's a comprehensive social challenges. It requires dialogue between government, educational institutions, civil society, and most important, with patients. Mexico is now fully committed to strengthening our tools to improve the mental health of our population and fully open to international cooperation in this regard. That's why I thank you for the invitation and for the opportunity to work closely with you. Thank you.
Thank you very much, Honorable Minister. Now, we have two panelists online, actually, joining us, beauty of the digital age. And so I would love to introduce our second panelist. Benjamin Bala is a person with lived experience of a mental health condition, shackling, and institutionalization. He is the General Secretary of Cultivation for Users Hope, a mental health organization in Liberia, and has been central to mental health law and policy reform work in Liberia. Benjamin, can you hear me from the other side? Yeah, I think you're on mute, Benjamin. Oh, you're still on mute, Benjamin. See if there's an unmute button on your screen. Wondering. Apologies, folks, for it's not a virtual hybrid event without a few technical difficulties. So we much appreciate your patience and understanding. This is probably the moment where I insert some like global mental health jokes, but I don't have any, so. We will actually move to our panelist, Suzanne Jabour, as we get Benjamin sorted. So I would love to introduce Suzanne Jabour, is the CEO of Restart Center and a member of the United Nations Subcommittee on Prevention of Torture. Suzanne Jabour is a human rights advocate and prominent expert in the prevention of torture and ill treatment, with extensive experience in the fields of rehabilitation, justice reform, and monitoring places of deprivation of liberty. Please welcome Suzanne to provide her remarks.
Thank you so much, Excellencies, distinguished colleagues, esteemed panelists and guests, good afternoon. I would like to thank you, the organizer, for convening this discussion. It's a pleasure to be part of this panel and to share with you some of what arises from my work within the SPT and as a mental health practitioner. The SPT, operating under the optional protocol to the Convention Against Torture, OHCHR, has the mandate to visit places of deprivation of liberty, engage with the state, and provide recommendations to prevent torture and repeat. This includes traditional detention settings such as prison and police custody, but also other closed institutions like psychiatric hospital, facilities for persons with disabilities, elder care homes, and facilities. As part of its mandate, the SPT also supports states in establishing national preventive mechanisms, or NPM. Do you hear me well? Do you hear me? Okay, can I continue? Yeah.
Yes.
Okay, thank you. As part of its mandate, the SPT also supports the state in establishing the national preventive mechanism, NPM, independent bodies that also access and monitor detention conditions. The discussion on mental health must not stop at the gates of prison or the walls of closed institutions, as human rights must reach every space, especially where individuals face heightened vulnerability. Yet, many detainees and or individuals find themselves in such institutions, especially precisely because of mental health conditions. One side once inside, environment that prioritize control over rehabilitation frequently exacerbate their struggles, reinforcing the very stereotypes that lead to their confinement in the first place and perpetuating a cycle of institutionalization. A major challenge in mental health care within places of deprivation of liberty is the issue of consent and autonomy. Individuals with mental health conditions are often subjected to treatment without their voluntary consent, justified by notion of control and safety. The Convention on the Right of Persons with Disability (CRPD) provides critical guidance in this regard. Article 12 of the CRPD guarantees legal recognition before the law on an equal basis with others, emphasizing that persons with disability, including those with mental health conditions, have the right to make their own decision about their treatment. Article 14 of the CRPD safeguards the rights to liberty and security, stating that a person with disability should not be unlawful or arbitrarily deprived of their liberty. Disregarding the autonomy, this autonomy through institutional practices is therefore not just problematic, it's incompatible with the human rights standards. The SPT experience shows that legislation on mental health context is often outdated or absent, lacking protocols such as those for involuntary treatment or criteria for hospitalization. For instance, can a young boy with epilepsy simply dropped off by his mother at a psychiatric hospital just because a seizure was mistaken for a mental health issue? Additionally, in many countries, health services in prison do not fall under the jurisdiction of health ministries. States often hesitate to move away from institutionalized care due to the financial constraint or misconception about the cost effectiveness of community-based models. The United Nations standards rules for the treatment of prisoners, known as the Nelson Mandela rules, stipulate that individuals deprived of liberty must enjoy the same standards of health care as those available in community. To support this principle, the SPT recommended that the state develop comprehensive mental health legislation that explicitly safeguards the rights of individuals in places of deprivation of liberty or any closed institution. Moreover, aligning detention health services within national mental health strategy bridges the gap between policy and practice, leading to a more humane and right-based approach. The further embed at a right-based approach, we also strongly advocate for training personnel on established framework, such as the WHO Quality Rights Initiative, the Mandela Rules, the Istanbul Protocol for documenting torture, and the Bangkok Rules for addressing the specific needs of women in detention. During our monitoring visit, the WHO OHCHR guidance on eliminating coercive practices serve as a key reference for assessing how states address the issue of restraint and seclusion, the presence of clear de-escalation protocol, and whether incidents are properly documented and reported. Ensuring these recommendations are consistently applied requires independent bodies conducting an announced visit. And this is where MPMs play a crucial role. The SPT cooperate with the state to strengthen MPM national preventive mechanism by ensuring they have the necessary independence, resources, and authority to carry out an announced visit and monitor conditions. Their work is essential to make sure that places like psychiatric hospital and similar institutions do not operate in isolation from scrutiny and the public oversight. The cost of failing to humanize mental health care in places of deprivation of liberty and in another closed institution far outweigh the investment required to implement a humane and community-based care. Moving toward deinstitutionalizations and embedding human rights within mental health governance is not just an ethical imperative. It's a practical and sustainable strategy that aligns with international standards. It is our responsibility to make sure that no one is left behind simply because they are inclusive institutions. Thank you.
Yeah. Hello? Audio now. Audio is- Yeah. Hello, Mohammed. Hello.
Dignity, autonomy,
Hello.
and informed consent while advocating for community integration and independent living. India is gradually moving away from long-term institutional care, with the majority of mental health services now delivered through general hospital psychiatry units, district hospitals, and community-based settings. Institutional care is viewed today as a last resort, reserved for cases requiring intensive supervision and always under conditions that safeguard human rights. Key national initiatives support this transition. The District Mental Health Program, DMHP, provides services at the grassroots level, reducing dependence on institutions. The Telemanas helpline, which is a 24/7 mental health line, extends access to mental health support in remote and underserved areas. India is also enhancing community rehabilitation infrastructure, including halfway homes, supported housing, and vocational training centers to enable individuals to reintegrate into society with dignity and support. The comprehensive primary health care Ayushman Arogya Mandir initiative, which integrates mental health into primary care, is another major milestone in ensuring early diagnosis and mental health services that are accessible, available, and integrated at the community level. The National Human Rights Commission, NHRC, plays an instrumental role by monitoring mental health institutions and advocating for the dignity and rights of persons with mental illness. Their oversight ensures accountability and drives policy reforms in line with global human rights standards. Nonetheless, we acknowledge that challenges remain, such as stigma, underfunding, and a shortage of trained professionals. To address this, the government has substantially increased postgraduate psychiatry training seats, expanded mental health education, and focused on developing community-based rehabilitation services. We remain committed to learning from global partners, sharing our experiences, and working collaboratively to ensure that every individual has access to mental health care that is inclusive, dignified, and just. Namaste.
Thank you so much. I ask Dr. Leslie Ramsamy, MP, Ambassador, Permanent Mission of the Cooperative Republic of Guyana, to provide the intervention.
Thank you very much. Thank you to Brazil, Mexico, and Portugal for helping co-sponsor this event, and to all the young people who have worked together to put this. Let me just say this, that mental health needs champions. We have never had enough champions. If you look at all the health issues, whether it's HIV, AIDS, diabetes, cancer, we have champions. But the good news is there's a growing number of champions for mental health. And whilst it's late in coming, I do believe that one day soon, mental health will occupy the space in our national budgets that it so sorely deserves. Mental health is part of our everyday lives, every minute, everywhere. These young people were stressed out, trying to get Benjamin on. And I have about 10 hours of story to tell you about what we have been doing in Guyana, but they tell me I only have 2 minutes. So what I'm trying to say is, as we get into our communities, we need to demystify mental health, make it too complicated. And we need to let every family know that mental health is part of their everyday lives. When families try to balance the budget, their mental health is tested. But our concept of mental health has always been wrong. I want to say that I've heard 2 speakers today, the Minister of Health from Mexico and our representative from India, talk about deinstitutionalizing the care for mental health. I think we should start making a list through human rights, for example, in UPR, of how many countries are doing that now. Guyana in 2022 replaced an old colonial, archaic law that essentially denied people their human rights. Some of the conditions under which people were held were worse than some of the worst prisons in the world. In 2022, we enacted a transformative modern mental health legislation that took a human rights approach to mental health, aligning with some of the UN rights obligations, such as the Convention on Rights of Persons with Disabilities. The law replaced the draconian colonial ordinance from 1930, which took an approach of secluding people away, locking them away. Today, we are trying to reintegrate those who have been in such seclusion for decades sometimes. The Ministry of Health, the government of Guyana, led by the president himself, recognized that we're not spending too much on mental health. When I became Minister of Health many years ago, we were spending less than 0.1% on mental health. But that was a story of all the developing countries. It wasn't just Guyana.
And by the time I left, it was 0.1. It was increased by 10 times. Today, I'm glad to say, no, I shouldn't say happy to say, we're getting in the right direction. It's 0.5%. The global average is 2%. But most developing countries spend far less than 0.5%. We have brought mental health programs in schools with the young people and adolescents. We have Gatekeepers program. We have a Let's Chat program with a hotline, a 915 hotline, so that we have not just the doctors and the nurses and so, but people could talk to each other. And now we have a package of mental health services as part of the public health sector that brings mental health into the primary health care centers and throughout the health sector. We are training more people. Wish I could go into details on all of these things, but in 2000, few ministers of health spoke about mental health. There were a few of us. One was a minister from Mexico, Minister Julio Frank. And we placed it on the agenda. We need to place it even more firmly on the health agenda. I'll end with this. Yes, we have put it on agendas and we have occasions like these, but we don't follow up. We don't follow up enough. The time has come for us to not just throw in a few targets in the SDG to satisfy those people like me. It is time that mental health occupy the debate space, the financial space, and I hope that through the next set of UPRs, countries are obligated to report what they are doing for mental health. In the meanwhile, to the young people, I say, it may not be the sexiest area to get involved in. It is the most needed area to get involved in. So my office in Geneva and the Ministry of Health of Guyana and the President of Guyana himself, we all have a place for you. Anything we can do, ask us, because mental health must be with us every day, every minute, everywhere, in every country. Thank you all very much.
Thank you so much for those empowering and inspiring words. Now, I have some good news. We do have Benjamin back online, but we will get to our last intervention, and then we'll move on to Benjamin. We don't want to miss him, so I'm thrilled that we were able to sort out the technical difficulties. Thank you for your patience, everyone. For Renee Vandervals, Coordinator, Mental Health and Psychosocial Support, Ministry of Foreign Affairs, Kingdom of the Netherlands, I invite you to provide your intervention.
Thank you so very much, Your Excellencies and colleagues. I hope you can hear me well.
Yes.
I will. Thank you. Really important and inspiring words have been said already by earlier speakers. Tara Klein said change is possible, and I think it's very important to keep that in mind always. I think the previous speaker alluded to the need for financial space. I think there's also a need for policy space to work to provide those that try to provide access to quality mental health, to provide them with the space they need. And I think the public space has grown enormously over the past years. I would like to refer to yet another part of the world in which we need to make sure that mental health and psychosocial support is provided, and that is where there are humanitarian and conflict emergencies ongoing. And actually, I would like to highlight that probably in more regular surroundings, we have a lot to learn from humanitarian actors and from those organizations that are working in fragile settings, providing mental health and psychosocial support access across clusters and across sectors. Because when you talk about deinstitutionalization, you also talk more explicitly about the responsibilities of other ministries and other clusters, also in integrating mental health and psychosocial support in their work. And in that field, there is a lot of experience in community-based approaches which are feasible. Change is possible, which can be organized even in acute humanitarian settings. I think it is also good to recognize that there are quite a number of countries that have been confronted with compounding crises, and that actually they turn out to be better prepared for newly arising mental health and psychosocial needs that come with crisis, and that this higher preparedness is not a preparedness which sits in institutions, but rather which sits in communities and in community-based organizations. And after the COVID crisis, a very good Lancet article was published in February 2021, which also alluded to this higher level of preparedness in countries with maybe not as strong health systems as some others, and that countries with stronger health systems can learn a lot from countries that live through consecutive humanitarian and other crises. And then I think here Ukraine is a good example, where at the same time urgent mental health care is provided both to those with pre-existing conditions and those which have conditions which arose with conflict. But at the same time, Ukraine is transforming its mental health system. And this again shows that it is possible. There's one element which really deserves attention as well in huge humanitarian crises and disasters, and that's of course the position of those with pre-existing conditions that are institutionalized. And in too often the institutions in which they are institutionalized are not prepared for a change in circumstances. And thus, these are people which then are triply or fourth times affected more seriously by the crisis than any others. I am sorry that there are some noise and sound issues, I think, but I hope I did come across, and I hope especially that I sufficiently referred back to what earlier speakers have told. Thank you so much.
Thank you so much, Renee. We heard you well, loud and clear. Benjamin, hi.
Good afternoon.
Yay, we got him. I will let you have the floor, Benjamin.
Hi, good afternoon, everyone from West Africa, Republic of Liberia. My name is Benjamin Bala. I am from Cultivation for Users Hope. I'm the General Secretary of Cultivation for Users Hope. CFUH, Cultivation for Users Hope, is a live experience movement, an organization run by seven users themselves, live experience people. We have our president, Bill OHCHR. Yeah, he's not in office today, But I've come to share with you what previous speakers have just said, just to buttress what they have said. So we keep talking about deinstitutionalization that the Minister of Mexico said. So all of these things are important, but for us from the lived experience, and we need to talk more about community mental health, community-based mental health care, and move away from institution a bit. Because medical model is good, but sometimes getting down to the community will help us to get our message across. And that's what Cultivation for Youth also have been doing through the help of the Carter Center of Mental Health Program here in Liberia and the United for Global Mental Health. They have been working with us in reaching down in our rural communities and even outside of Liberia. So I am a victim of what we are talking about. I'm a lived experience from mental health, and I know what I went through, and I don't want anybody else in the world, in Liberia, and everywhere to go through what I went through. Like this, the speaker that just left the line, Renat, she remember me very well when we talk about shackling. I also share my story in that particular meeting. Today, I have an opportunity to be here to tell you what we do in Liberia. Here, Cultivation has been able to reduce stigma to a certain level, draw our government attention to mental health, make sure that mental health is no longer under the rock in our country, but mental health should be posted on our national agenda. And we have been also instrumental in drafting, helping our government, helping policymakers to input in our policies that have to affect mental people with lived experience or psychosocial disability. We need this. People with lived experience need to be involved in various policies that are developed around the world, or that to make sure that they are part of these instruments. Well, when we develop the instrument together, we know, because there's a common saying that says, it is only he who wears the shoes know where the shoe pinches. We are the right beneficiary of these things we are talking about. I was beaten, I was shackled, and I was kept in a special place. We're talking about deinstitutionalization. And CFA is so much against this, like keeping people in special places. Those things, we need to get down to the community, get to our family members, get to our caregivers, and make sure that we have this message across. United Nations, WHO always is committed to doing that. United for Global Mental Health has been very instrumental. So our major barrier here is funding opportunities. I can remember back in our country, there was no budget line for mental health. This in Cultivation for Youth of Hope have to take placards. They went to the parliament. Today in Liberia, we have a budget line in our health budget for mental health. So we are strong advocates for people with psychosocial disability in our country and outside of our country. We have been able to travel to Freetown, Sierra Leone through the instrumentality of United for Global Mental Health to share our experiences on the ground with our colleagues in our sub-region to make sure that mental health is a priority. There is no health without mental health. So we have been able to pressure our government last month, the latest part last month. The Ministry of Health in Liberia broke ground to pay one of the biggest psychiatric hospitals in our country. Unlike today, we have 80 beds, a psychiatric hospital in the Tuporo, in the suburb of Monrovia, that can even contain almost the entire country. So we need funding opportunities to make sure that we push our agenda. To get to the community, we need funding everywhere around the world to talk about mental health. So we have to do this to make sure we reduce stigma and discrimination, because we need better mental health care for everybody. There is no health without mental health, and we will not rest. I live experienced people in our country and outside of Liberia. We will not rest until we make sure that mental health is being supported in our country and the world at large. Before I leave, I would like to leave you, major supporters, our caregivers, with this. If people with mental health conditions are supported and provided the needed care they need, they also can contribute meaningfully to our society. As I said here, I relapsed several times, but I was able, through my caregivers, my elder brother Clarence Bala, I was able to graduate from University of Liberia. Today, I'm a school teacher. Today, I work for Coordination for Use of Youth. And I don't want anyone, anywhere around the world, to go through what I went through to get to this level, to be a degree holder, to be a school teacher. If anywhere around the world, people with psychosocial disability are supported, they are able to do what, quote unquote, any other normal person can do. Remember, at some point in your life, no one go for mental health, no one pay for mental illness or psychosocial disability. At any point in your life, you could be a victim of this. Let us avoid stigma, discrimination, like our team for the World Mental Health Day last year, and we need to prioritize mental health in the workplace. Thank you so much for organizing this event. Thank you to the organizers. Thank you to the donors. Thank you to United Global Mental Health. And say thank you so much for giving me the opportunity to hear my voice, to tell you that I'm a lived experience person in this country, Liberia, and the world, pushing for a better mental health. Thank you so much.
I want to emphasize just how courageous it is to be at this forum, Benjamin, and speak to your lived experiences. Your policy and advocacy work in Liberia and in this forum is so necessary and so needed. With respect to the time, we are going to move to the second panel. And so I would like to invite the second panelists to come and sit at the panel, and we will get started with the second element. So we'll be following a very similar format to the first panel. I will provide introductions to each of our distinguished panelists. They'll be provided some time to provide their perspectives. This panel is on advancing global commitments to mental health and human rights. And I will maybe provide 10 seconds for folks to quiet down and get comfortable in their seats again. And okay. So we have 4 incredible folks here today. I want to invite Ambassador Mira Gomez to provide his opening his remarks. He's at the Permanent Mission of Portugal. Previously, he was Secretary of State for National Defense and Maritime Affairs and representative to the EU Political and Security Committee and permanent representative to the Western European Union. Please share your remarks. That would be amazing. Thank you.
Well, good afternoon to everybody. Thank you so much for the invitation. It's a pleasure to be here. And about being comfortable, I have always a theory: if you are not feeling comfortable where you're sitting, you pay more attention to what people say, and that is also one of the theory when you go to Bayreuth for the music festival, and I think it's also the case here. I hope that I will be able to contribute something to this discussion today, and I will speak more from the perspective of the governmental policies, and human rights. But let me say that from the outset, that Portugal, together with Brazil, we were the first ones to bring mental health and human rights to the agenda of the Human Rights Council back in 2016. And since then, 4 resolutions have been adopted by consensus. The last one, in 2023, had meaningful follow-up. Why? Because it requested the organization of consultations in 2024 that resulted in a report released last March. It is very important that mental health issues are sufficiently addressed in the works of the 78th World Health Assembly. More importantly so, discussions on mental health should be human rights based, as we have listened here this morning. And from a Geneva perspective, Portugal is proud to have contributed in recent years to breaking the silos between the Human Rights Council and the World Health Assembly on this topic. Our commitment is driven by 4 factors. Firstly, we firmly believe in the universality of the right to the highest attainable standard of physical and mental health, which must be respected by all states. This is a universal right. Addressing mental health through a human rights perspective contributes to holding states accountable for their international obligations. Secondly, we are proud to have been one of the main advocates of a human rights-based approach to mental health. Portugal's resolution does not focus primarily on mental health as a right on its own. It addresses the need to eliminate discrimination, stigma, and violence associated with mental health from a human rights perspective. In line with the Convention on the Rights of Persons with Disabilities, the WHO's Quality Rights Initiative, as well as the Committee on the Rights of Persons with Disabilities guidelines on deinstitutionalisation. Thirdly, mental health intersects with public health and social justice. It is essential in order to achieve sustainable and inclusive development. Neglecting mental health can perpetuate inequalities and hinder social progress. Finally, we acknowledge that existing mental health-related legislation often falls short of its objectives. This perpetuates human rights violations, including the denial of the individual's autonomy and legal capacity, coercive practices, institutionalization, substandard services within mental health facilities, as well as over-medicalization and treatment practices that fail to respect their autonomy, will, and preferences. In response to these pressing challenges, our commitment to this cause extends to the UN agencies that champion this issue. We certainly need champions, and the first champion has to be the United Nations. In this regard, Portugal has supported the mental health agenda, specifically the WHO's mental health program and the Quality Rights Initiative for the past 5 years, including through voluntary monetary contributions. In the past year, we have been supporting the making of the WHO Quality Rights e-training program available in Portuguese, recognizing the vast number of Portuguese speakers all worldwide. With an estimated of over 260 million Portuguese speakers in 5 continents, this translation will be a powerful tool for change. At the national level, we have established a national mental health policy coordination and reviewed our mental health legislation, aiming to strengthen our governance model and its rights-based approach. We are making tangible efforts to end institutionalization in the context of mental health and replacing it with community-based support services. Discussions like this one here today are important in raising awareness about state obligations. We hope it will also encourage integration of rights-based mental health considerations into general legislation. As part of our efforts, Portugal will be presenting the next interaction of the resolution on mental health and human rights at the Human Rights Council in March 2026. By aligning our policies and practices in this field with international human rights law and relevant guidance documents, together we can harness its power to transform our approach to mental health. Let us commit ourselves to ensuring that no one is left behind on this matter. Thank you very much.
Thank you, Ambassador. I'd like to now welcome Pradeep Wagla, Chief of the Economic, Social, and Cultural Rights Section with the OHCHR. Previously, he was the country representative of the High Commissioner for Human Rights in Cambodia. He has also worked as a lawyer in various other capacities with local and international human rights organizations and academic institutions in Nepal and South Asia. Thank you, Pradeep.
Thank you, Madam. Excellencies, colleagues, friends, good afternoon. In my very short intervention, I would like to build on some of the key messages that have been already conveyed by our esteemed speakers, and also share with you some of our work as the Office of the Human Rights in mental health and human rights. Let me allow to reiterate, and I hope you will agree to reiterate with me, that mental health is essential to realize the right to health. It is also essential, more broadly speaking, to realize other human rights and fundamental freedoms. The widespread human rights violations that have been reported and documented and harm caused by mental health systems that has led to a legacy of trauma that impacts many individuals and communities and spans generations. Stigmatization, sorry for my mumble, discrimination and harmful practices have affected persons engaged with mental health systems. Persons with psychosocial disability and users of mental health systems are frequently deprived of their legal capacity, a fundamental cornerstone of human dignity and human rights, with regard to accepting or rejecting treatment and admissions to hospital, leading to institutionalization in mental health facilities. Access to mental health care services is a major human rights challenge globally, which affects groups in marginalization and improvised situation due to stigma, fragmented services, high cost, lack of insurance coverage, and all very simply unavailability of the mental health services. It is fundamental human rights concern that a significant majority of those who need mental health care lack access to quality mental health services. Mental health system urgently needs systematic reform, which prioritizes a human rights-based approach. This is fundamental element of the right to health. This is one of the main conclusions of our comprehensive report on mental health and human rights, which was presented to the Human Rights Council in March this year, pursuant to its resolution 5212. The comprehensive report contains an analysis of the main obstacles and challenges in applying a human rights-based approach to mental health. It is the fruit of a one-day consultation that was held last October on the challenges and best ways to implement at local, national, and regional levels, enabling normative and policy measures for the realization of the human rights of persons with psychosocial disability and current or potential user of mental health services. Most importantly, the report highlights that human rights provide an actionable framework to transform and shift the paradigm on mental health from a narrow and biomedical approach, which has contributed to coercive environments in mental health services, to a holistic and inclusive understanding of mental health, therefore to community-based mental health care. But what does this mean concretely? This requires mental health system that not only focus on diagnosis or medication at the expense of neglecting the determinants affecting people's mental health, which also results from poverty, violence, discrimination, from human rights violations. It requires an understanding that differentiate and intersectional forms of discrimination experienced by different groups in accessing mental health services, and thus adopting a person-centered approach to mental health system. Therefore, users and survivors of psychiatry should actively be involved through meaningful participation in decision-making process about mental health systems. It also requires changes in legislations and policies on mental health, which legitimized and in some cases, unfortunately, facilitates human rights violation. In 2023, our office produced jointly with the WHO, the Mental Health, Human Rights and Legislation Guidance, with the aim to guide and support countries and other stakeholders towards embarking on a legislative reform related to mental health that are required by the human rights framework. The guidance encourages the integration of mental health into general legislation rather than adoption of mental health specific laws, and proposes a set of key provisions that countries should adopt to support a human rights-based approach to mental health, which covers equality and non-discrimination, personhood and legal capacity, informed consent, eliminating coercive practices, access to quality mental health services, implementing mental health services in the community, full and effective participation in public decisions, accountability, and cross-sectoral reform. In this context, we are strongly committed to supporting countries in the conduct of human rights-based assessment of their mental health systems and using the guidance for drafting and enacting of mental health legislations that upholds human rights and fundamental freedoms. We are also committed to engaging with governments in operationalizing human rights-based approach to mental health. In Somalia, for example, we supported a baseline assessment of the right to health and access to health care, including mental health and services of minorities, displaced, and other groups in marginalized situations through a gender perspective to inform the upcoming national health strategy. Strengthening health system also requires adequate public funding to the maximum of states' available capacity. In this context, in Kazakhstan and Kyrgyzstan, we have engaged with government actors in conducting a human rights-based budget analysis for the realization of right to health. Please, colleagues, engage with the recommendations in the comprehensive report that I mentioned and engage with the mental health and human rights legislation guidance. We stand ready to work with you and all relevant stakeholders towards this implementation of these policy tools. I thank you for your attention. Thank you.
Thank you, Pradeep. Devorah Castell is the Director of Mental Health, Brain Health, and Substance Use at the WHO. She is a senior global mental health policy expert and a fierce advocate for the rights of people with mental health issues. Please, Devorah. Please welcome Devorah, everyone.
And we are all supposed to be maybe somewhere else, so that is running a bit late. And I wanted to say that nearly 40 years ago, 40, wow, I stepped in a psychiatric hospital for the first time while I was a student in my home country in Argentina. And I couldn't understand why people were treated in such a way just for being a person with a mental health condition. The need to change that brought me to where I am today, and this role as director of this department. And so I'm not going to tell you all what I did in those 40 years, or what I think about the topic, but I will read a few issues, trying to skip those that were already mentioned to make it sure that we can respect a bit the time we were giving. Of course, thank you to the organizers. This was a magnificent event, and the level of attention and participation of high representatives from governments, those co-hosting Brazil, Mexico, and Portugal, and the audience shows the interest and the need to go deeper on this topic. We have been working very closely with the Human Rights Council, and issues were already mentioned, and I'm not going to repeat, but we have launched recently, the quality rights was also mentioned before, and recently we launched 2 documents. The one just mentioned in collaboration with the Commission that was the guidance on mental health, human rights, and legislation. And just recently, a few weeks ago, we released a new guidance on mental health policy and strategic action plans. Together, these frameworks provide countries with guidance to drive the systemic transformation that is urgently needed in almost all countries of the world. And they offer clear and actionable direction on how law and policy can advance the institutionalization, building a sustainable community-based support system. But because the process of the institutionalization is different from country to country, and the needs around how to do it are huge, and the process is so complex and complicated, we are developing a practical guide to support the transition of long-stay residents with severe mental health conditions from psychiatric hospitals to community-based care. We hear a lot talking about mental health. Ambassador Ramsamy, I was going to Guyana when he was a minister back then, and he used to say we are all illiterate when it comes to mental health. I think now we are more literate than back then, but still there is a lot of talking about mental health and well-being of some form of problems, but a tendency to still ignore those the needs of people that then end up in an institution and penalized for life, them and their families. So we think that intervening there is needed. So we aim to support with this guidance senior decision makers at all levels, but particularly psychiatric hospital directors in leading effective reform. These products, all of them, make it clear that the institutionalization is not about moving people from one building to another. It is about transforming how we understand and deliver mental health care, building relationships of trust, not control, and supporting people to live the lives they choose. We continue with continued leadership from countries like the ones here today, and the voices of people with lived experience, as we also heard here today, at the center of the process. We can finally see the day when we will replace institutions with community-based systems and of support that will uphold freedom, dignity, and inclusion for all. Thank you very much.
Thank you, Devorah. And our final panelist, Zion. Ame Abba is the founder and president of Mandate Health Empowerment Initiative NGO in Nigeria and a co-chair of the Data and Research Working Group of the Global Mental Health Action Network. Please welcome Zion to the stage, please.
Okay, thank you very much for having me. This a very wonderful side event. Let me particularly appreciate United for Global Mental Health for putting this together along your partners. I need your support. I will want us to re-echo some few words together. I believe you seated here participating in this side event is a clear indication of your solidarity to mental health and human rights. So can we please together echo these 3 lines of words? Our rights, our future, right now. Want to go? Our rights, our future, right now. Please say it like you're supporting me, even if you don't mean it, right? Just that you're supporting me. Want to go? Our rights, our future, right now. There is never a better time than right now having conversations around mental health and human rights. Distinguished ladies and gentlemen, Your Excellency seated here, I make bold to have you know, just like we have heard from Dr. Michel, who said again and again that mental health systems rooted in institutionalization are a relic to injustice, stigma, and neglect. Went further again to do mention that the institutionalization is not a mere reform. Distinguished ladies and gentlemen, it is a human rights imperative. I want to say here, as I make a little presentation to also showcase what is happening in Nigeria with respect to mental health and human rights, I would like to please let you know we are no longer in the days of the archaic, antiquated Lunacy Act of 1958. We have survived that era. We have moved right now to having a Mental Health Act 2021. However, just like we heard the former minister from Ghana re-emphasize on the issues of legislations and policies, what exactly is the level of implementation? When we have all of these beautiful legislations and pieces of policies that addresses mental health and human rights, very good, fantastic. But what exactly is the implementation to showing and to supporting people who come down with mental health conditions? Distinguished ladies and gentlemen, I would just like to read a few of the rights as enshrined in the National Mental Health Act 2021 for Nigeria, as gazetted. Now, a few of it shows that the rights of persons with mental health conditions are enjoying protection in the Act, including the following: rights to access mental health services when needed, rights to quality and standard of treatment in healthcare facilities, rights to be protected from torture, cruelty, forced labor, and any other form of inhuman treatment, right to enjoy equal access to work and employment opportunities, rights to retain employment, employer support, and housing benefits while undergoing mental health treatment, rights to exercise the capacity to make decisions, actively participate in treatment plan formulation, and appointment of a person as legal representative, right to appeal decisions of mental health assessment committee on involuntary treatment, right to privacy of visitors and dignity, right to access personal medical information, right to confidentiality, and rights and rights and rights. So many rights. But how much of these rights are we upholding? How much of these rights today can we say clearly are being practiced or upheld? Nigeria's mental health care system historically has been institutional centered, where we have the psychiatric hospitals lead and remain the model for care for people who come down with mental health or other related illnesses. And the shocking thing is this: in these psychiatric facilities, it has been recorded that below minimum human rights standards have been experienced. We have seen clearly how overcrowding, lack of psychosocial support, and limited integrated programs continue to persist. I say this not because I want you to hear my voice, not because I'm singing it, as I do not have a very good voice for singing. But I say this just to have you know what is the current realities, not just in Nigeria, not just in Africa, but across the global communities. And so that you seated here can also add your voices, and let's change the narrative. Let's truly bring to bear all of these rights that are enshrined in our legislation, that are enshrined in our policies, to be practically implemented. Let me not bore you too much, but let me say this. In the spirit of leaving no one behind, just as stated earlier by the previous speaker, we must re-image care to enable recovery. We must re-image care in the spirit of leaving no one behind to enable perfection and also empowerment. Let me quickly round up with this quotation. Mental health care must be shifted from custodial and centralized institutions to community-based, person-centered, and right-based systems. Distinguished ladies and gentlemen, I have some few recommendations here, as I also do have the privilege of participating in a serious work that was put together for the policy brief for the deinstitutionalization. Please again, give me your attention and hear these few recommendations, so that you can help us re-echo it in your community, help us re-echo it to your government and the key stakeholders that you feel can help us drive these recommendations to limelight. Number one, we must prioritize human dignity in all settings. Where we care and respect patients' choices about their treatment and focus on improving their overall quality of life through cross-sectional coordination and integration of mental health care into health education, housing, welfare, and the justice sector. Another recommendation will be to review and reform laws that allow for involuntary admission, forced treatment, and indefinite institutionalization. May I also please, distinguished ladies and gentlemen, add that we must increase government budgetary allocation for mental health service reform. This is not to make light of the commitments that we see from international development partners as touching deinstitutionalization or mental health. However, I want to reemphasize that we must ensure sustainable funding mechanisms beyond pilot projects, especially in development nations. May I also quickly add, distinguished ladies and gentlemen, that it is very important that we build capacity and empower people with mental health condition already living in institutions, so that they can add their voices. I'm very happy to hear the voices of some lived experience persons speak today, like the voices of Benjamin. Let's continue to empower them and build the capacity so that voices can be heard. Again, as I round up, please hear me. I want to also request that we must strengthen the collection of data on institutions and community-based alternatives to support evidence-based policy making and practices, and ensure mental health indicators are included in national development plans. As I round up, so that I do not hold this mic for long, please hear this statement. I have two statements I like to leave. The first is, deinstitutionalization is not the end. It is the beginning of building compassionate and resilient communities that embraces mental health as essential to human rights and development. Let me add one more before I go. Just in closing, please. Deinstitutionalization without investment in community care is another dimension or another way of abandoning people in a very modern, nicer way. But that should not be what we should do. I call upon all stakeholders here. I call upon again the United Nations and all our stakeholders responsible on this very important and critical subject to please invest in community-based mental health care. Thank you very much for having me. I look forward to, again, further deliberations and commitment to this. God bless you all.
Thank you so much, Zion. If we could spend days, weeks, months on this topic, and because we are short for time, I do have $1 million question that I welcome any of the panelists to provide their thoughts on. And it's one that I've personally been grappling with in my work within deinstitutionalization and transitioning towards community approaches. We're all part of the community that knows that deinstitutionalization is one of the ways in which we can embody more of the values of a humane, compassionate, person-centered mental health care. But it is a polarizing issue, it's a contentious one, and it's oftentimes controversial. And so within your global advocacy work, within your ambassadorial work, within your community, what would you say to those who push back against the idea of deinstitutionalizing mental health care and transitioning towards community mental health care? What would be that thing that you say to them to bring them to the other side of seeing what we see?
Do I need to be polite? Yes, I have to. Because I would say, would you send to one of these institutions your daughter, your son, your mother, your brother, your father, your loved one? Would you send that person there and lock the key, throw the key away, lock the door, throw the key away for 20, 30 years? Or are you concerned about the life of those people and the possibilities of those people and their families? Or are you concerned about the money that you put in your pocket if you have your private setting and forget about helping people in need? That's not polite. I said I will be polite, sorry. But because I think it is a big problem there. It's not having the commitment and the enthusiasm and the passion to change a situation that is changeable, because we have seen countries that could do it. So those who don't do it is because they're not really committed to have that hard work that is needed and initiate and move on with a change. So what I would say then in a more amicable way is have a look at in those places where the transformation took place and try to learn what needs to be done, how to do it, and that's the polite guidance that we are also doing, saying, okay, how do you need to do it? Because it's not easy, it's a complex place, there is no money allocated, and there is a comprehensive change that is needed. It's doable, it can be done, a step at a time. These are the guidance on how to do it.
Thank you. Any other perspectives?
Well, I have to be polite and I have to be diplomatic. But from the governmental perspective, I think, and also looking to the human rights angle of the question, I think it would be already a progress if
each and single country in their UPR review would include mental health as a mandatory topic. It would make a difference. Countries and governments would feel more responsible, and it would be also a guidance working together with WHO on how to address this very important topic. We know that we have different levels of development, but if we can have some kind of a common engagement around this topic, I think it would make a difference.
Thank you. And Zion, did you have a couple words?
Thank you very much. I also would just want to add a little to that responses already given. And my point will be that, you see, where there are close to zero leadership and political will on this subject matter, you will always see that there is no clear support or willingness, to support deinstitutionalization. And my call will be that for our politicians who might not see anything in need for them, because that is usually the route that they will want to go, they will not be willingly open to be committed to any change that will not advance their political careers. We've seen that a lot. Right? So, however, I'm saying this, that we have seen again and again that deinstitutionalization is going to reduce stigma, is going to give patients autonomy, is going to also help people to be able to recover and get access to care. So please let us ensure that there is commitment, okay, from our leaders, whether at executive level, whether at the judiciary level, whether at the legislature level. Let's drive to keep knocking their doors to ensure that there is a deliberate commitment to deinstitutionalization. Why? Because it is profiting.
Thank you. And I have a question for you, Pradeep. You mentioned something very interesting in your remarks about operationalizing mental health within the structures and the legislation of countries. And I wanted to see if you could share a little bit about that. What are the key ways that we can operationalize deinstitutionalization or community-based mental health care instead of, and have it be measurable and tangible? Just a few thoughts, and then we'll close out with the closing.
So I was hoping some easy questions. Look, when I say operationalization, I was referring to actual implementation. We talk, we have guidance, we have laws, principles, and policies. What we want to do is to engage with stakeholders to actually see how can we narrow it down and apply these principles in a context that is in front of us. In a context that has problems and tries to find solutions. Where when we say operationalization, we're talking about bringing rights closely, and actual realization by everyone who is in need of it.
Thank you, Pradeep. Thank you to the panelists. And I will just close things off. But for those who have been so committed and so passionate about this topic, we'd love to take a photo at the very end. So if you'd like to participate in that, please stick around. Thank you to all our panelists, co-sponsors, and participants, both here and online, for being part of this vital conversation on mental health and human rights. What we heard today was clear. Deinstitutionalization is not just a policy goal. It's a moral and legal imperative. Around the world, too many people with mental health conditions are still denied their basic rights, locked away, silenced, or subjected to treatments they did not choose, often without the support of their families or communities. And yet, we also heard about what is possible. the promising reforms, the power of lived experience, and the communities that are showing us a better way. One where mental health care is rooted in dignity, autonomy, and human connection. One where care is not something done to people, but built with them. We must remember that human rights are not a luxury in mental health. They are a foundation. And the shift towards community-based care is not just a structural change. It is a paradigm shift in how we value and treat people. This is our moment to act. And yesterday was our moment to act. And tomorrow will be also our moment to act. With courage, with compassion, and with the understanding that mental health is not separate from the broader fight for justice and equity. It is at the very heart of it. So, I'd like to end things off with a reflective question. And if you feel comfortable, close your eyes. What would it look like? What could the world truly look like if every single person alive today and tomorrow had access to safe, timely, culturally meaningful mental health care? What if that care respected their innate right to dignity and personal autonomy? And what if this care was provided and integrated within their community where they were encouraged and supported to work, live, and play alongside their family, friends, colleagues? Would the world look different? Would it feel different? Because a world, and you can open your eyes now for those who are, because a world where every person, every single person, regardless of diagnosis, circumstance, or identity, can access rights-based, community-driven care. This world is not only imaginable, it is necessary. And if it's tangible in our imaginations, it can be made manifested into reality. So let's leave here today not only inspired, but mobilized. Let's carry this momentum into the week ahead at the World Health Assembly, into our national policies, and ultimately into our communities. Thank you so much for being with us today. Thank you. Photo time.
Still here. Come in, we're going to take an amazing picture.